Hello and welcome to the July 13th Virginia Opioid Abatement Authority Abatement Academy. My name is Jennifer Nelson, Virginia Institute of Government Assistant Director for Membership and Engagement. The Virginia Institute of Government is the leadership development and community engagement arm of the Weldon Cooper Center for Public Service at the University of Virginia. Through our research, leadership development programs, and local government engagement initiatives, we continue to work towards our vision of good governance, equity, and resilience in every Virginia community. VIG offers leadership development through SEI and LEAD, local government equity clinics, certification for treasurers and commissioners of the revenue, and customized training programs. State agencies and local governments can access a range of consultation and support services to build more resilient organizations. We have a team of seasoned public sector leaders and subject matter experts ready and available to facilitate boards of supervisors, city and town councils, leadership teams, strategic planning retreats, and other related events. Today, VIG is glad to partner with the Opioid Abatement Authority for the Abatement Academy series, presented every second and fourth Thursday through 2023. Here are a few housekeeping notes. This session will be recorded and posted on Weldon Cooper Center for Public Service YouTube channel soon. If you have any questions, please type them in the chat and I will ask them for you. Thanks again for taking the time to join us today for this Abatement Academy session. Now, I'm happy to turn things over to Adam Rosatelli, the Authority's Finance Director. Adam?
As Jennifer mentioned, my name is Adam Rosatelli and I'm the Director of Finance for the Opioid Abatement Authority. So this is the fifth installment of a series of free biweekly webinars launched by the Virginia Opioid Abatement Authority and the Virginia Institute of Government, the purpose of which is to highlight examples of programs that align with nationally recognized principles for the use of funds from opioid litigation. And for those of you in attendance who aren't already aware, the Opioid Abatement Authority is an independent body whose purpose is to abate and remediate the opioid epidemic in the Commonwealth through financial support from the Opioid Abatement Fund in the form of grants, donations, or other assistance for efforts to treat, prevent, and reduce opioid use disorder and the misuse of opioids in the Commonwealth. So for this Abatement Academy webinar, we are very fortunate to have Mr. Anthony Grimes with us today to discuss the topic of measuring the effectiveness of certified recovery homes in Virginia. So Anthony is Executive Director of the Virginia Association of Recovery Residences, or VAR. And Anthony is a person in long-term recovery from substance use disorders. He is a certified peer recovery specialist and has years of direct experience working with people in recovery. Through his passion for working with people new in recovery, in 2016, he started his first certified recovery residence. In 2017, Anthony co-founded the Willing Addicts Recovering, or WAR Foundation, a recovery residence foundation in Richmond, Virginia. The WAR Foundation has grown from 21 beds to currently 103 certified beds in Virginia. In 2019, Anthony was hired as the first full-time paid executive director of the Virginia Association of Recovery Residences, or VAR, which is the Virginia state affiliate of the National Alliance for Recovery Residences, or NAR. VAR certifies recovery residences throughout the Commonwealth of Virginia that meet the national standards set forth by NAR. VAR is also a credentialing entity for the Virginia Department of Behavioral Health and Developmental Services state certification. During Anthony's tenure, VAR has more than doubled in the number of certified recovery residents, operators, and bed capacity, and as of early 2023 has 1,170 certified beds. In 2020, VAR received its first budget amendment placed in the Commonwealth's budget, which has passed through the Virginia General Assembly, which allocated $250,000 a year to VAR for 2 years. In 2021, the second year of the budget line was increased to $500,000. This allowed for the first time in Virginia operators to receive indigent bed funding through VAR, thus allowing individuals access to quality recovery residences whose primary barrier to access recovery housing is a financial barrier. Through this, VAR data shows that the percentage of populations being served in VAR recovery residences went from 80% Caucasian and 20% non-Caucasian to 70% Caucasian and 30% non-Caucasian, indicating that minority populations' largest barrier to recovery residences is a financial barrier. In August 2021, the General Assembly reconvened for a special session to allocate funding from the American Rescue Plan Act, or ARPA. VAR received a $10 million allocation, which was used for additional indigent bed reimbursement for recovery residence operators, thus continuing to promote equitable access to safe, certified recovery housing. With these additional funds, VAR data shows the population served are 54% Caucasian and 46% non-Caucasian. Additionally, funds were used for expansion of certified residences in rural areas, as well as for minority ownership and mentorship program. Since VAR has continued to receive a budget line item in the Commonwealth's budget. Under Anthony's leadership, Virginia has also hosted the NAR Best Practices Summit in back-to-back years in Virginia, 2021 and 2022. Anthony co-authored a published research paper with leading addiction recovery researcher, Dr. David Best, and other esteemed colleagues. The study, entitled Using Recovery Capital to Predict Retention and Change in Recovery Residences in Virginia, USA, was published in 2023. Anthony was named to Style Weekly's Top 40 Under 40 class of 2023. And Anthony is proud and humbled to now be on the NAR board of directors. So pretty impressive stuff, Anthony. And again, we certainly welcome you here today to share your experiences with us. So thank you.
Well, thank you for the warm introduction. Good morning, everyone, and welcome. I want to preface before we get into the presentation and say that I believe that my wife made the coffee a little weaker this morning than I'm used to. So I'm really going to try my best to bring the energy that I always bring. But, if it's not quite up to your standards, please let me know and I'll convey that to my wife when I get home. Additionally, if you don't like anything that I present, I was asked to be here by Tony McDowell, not Jennifer Nelson or Adam Rossatelli. So please don't blame them. Send an email to Tony after I conclude, and you can share your grievances with him. So now that we have that housekeeping out of the way, we're going to get right into the presentation. So what is VAR? Essentially, VAR is the state affiliate of NAR. NAR is the National Alliance for Recovery Residences. NAR has about 38 state affiliates that are fully operational throughout the country, and another 6 or 7 that are in the affiliate development mode. NAR founded the most widely used and adopted and endorsed by SAMHSA, National Standard for Recovery Residences. And we'll get into a little bit about differences between sober living homes, halfway houses, 3/4 homes, and then what a recovery residence is. So here in Virginia, what we do is per our NAR affiliate agreement, we adopt the NAR standards, and then we implement those standards and operationalize them through a certification process to certify recovery residences that meet these rigorous standards. And then we are also a credentialing entity of the Department of Behavioral Health and Developmental Services, or DBHDS, which is certainly a mouthful. And we certify recovery residences that meet our standards. And through that certification process, they are eligible for the state certification. And how this came about was in 2017, VAR and the department engaged in conversations about a way to identify recovery houses that met national standards. And subsequently, legislation came out in 2018 through House Bill 2045, which called for a certification process for recovery residences across the Commonwealth. And VAR was written into code as a credentialing entity for that certification. And part of the NAR standards encompass a fundamental component of recovery housing is the social model of recovery. And through our standards, we're able to operationalize this philosophy and ensure that this is promoted. And one of the core components of the social model of recovery is community, is connection. And essentially, the relationships built in operating recovery residences are not those of a practitioner-client relationship, but more of a peer-to-peer relationship in which individuals have a voice in their recovery. And so a recovery residence denotes a safe and healthy residential environment in which skills for sustaining recovery are learned and practiced in a home-like setting based on the social model. Currently, we have 103 VAR certified recovery residences, which equates to about 1,117 certified beds, 30 unique recovery residence operators or organizations. And so that number has significantly grown. When I took over VAR in 2019 and became the first paid executive director for our board, we had about 280 certified beds at that time period. So we have continued to sustain meaningful growth, not at what I would call a rapid pace, but at a really quality-induced pace. And so when we talk about measuring the effectiveness of recovery housing in Virginia, one of the things that really became evident to me was I certainly wanted to advocate that our providers provided good quality recovery resident services. And one of the stigmas that has been associated with sober living homes, recovery residences for eternity is that the people that operate them essentially are just providing a bed. Now, I want to make this really clear. Recovery housing or sober living homes in their purest model, which is a group of individuals living together trying to achieve the common goal of recovery, is an evidence-based practice deemed by SAMHSA a few years back. That core component in itself is evidence-based. But one thing that was really important to us is that we wanted to demonstrate that recovery residences that are certified by VAR and our standards in Virginia, that they went above and beyond that. And so what we really wanted to do was demonstrate how recovery support services are actually delivered. And one of the things in working with the General Assembly I found was that we had no way to evidence this. For years, we would go down and we would advocate for certain things, bills that, supported referrals or fair housing or funding for indigent beds and things of that nature. And we would always come down there and we would bring people in recovery who are achieving sustainable recovery. And one of the knocks that we always got was, you can bring somebody down here, and a senator told me this offline, you can bring somebody down here and you can have them tell their story that they got a job, that they got access to any barriers to recovery they may have had, they got a better job, they engaged in mutual aid support groups or whatever the case may be. But really, as a recovery residence operator, you can't evidence that you delivered that service to them. And that really stuck with me on how do we find out a way to evidence that our recovery residence operators are delivering recovery support services that are peer-based. And so in early 2020, when we were looking at different data platforms and ways to quantify the great work that our Virginia providers were providing across the Commonwealth, we came across the ARMS platform, which contains the RECCAP system. And so what RECCAP is it's an evidence-based recovery care planning and measurement tool founded on the science of the world's leading addiction researcher, Dr. David Best. And to date, we have 90% of our VAR certified recovery residence beds that are in the RECCAP system, which provides us statewide data from all different regions across the state, localities, urban, rural, et cetera, on how changes in recovery capital, employment, and a plethora of different metrics may or may not change based upon location and a plethora of other things identified in the platform. And so what is recovery capital? To some people, it's still a bit of a newer concept, but Granfield and Cloud, have one of the best definitions that I particularly like. And it's really the breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from AOD. And then William White, who, if you don't know who William White is, he's really been the godfather, so to speak, of the peer support and recovery movement in our country. He identified it as stable recovery best predicted on the basis of recovery assets and not pathologies. And this really became really important for us here at VAR because, one of the things that we've seen is we have seen, over our country's history, a lot of funding really dedicated to the acute phase of an individual's recovery journey, or what we would call the treatment phase of it, which essentially can last 30 to 45 and then sometimes on an outpatient basis up to 90 or 120 days. But all the world's leading scientists, Dr. John Kelly from Harvard, Dr. David Best, Keith Humphreys over at Stanford, all the science tells us that in order for an individual to not be at a risk no greater than the general population to have an acute episode, then we need to get them to 5 years of stable, sustainable recovery. And so that 5-year metric, to me, lets me know that we need to be advocating for long-term recovery support services. Not that the acute care phase of an individual's journey isn't important, but as a country, we have kind of really relied upon this treatment phase of an individual's journey. And what we haven't done is done a great job of investing in long-term recovery. And so that's one of the things that we've been able to demonstrate as a result of this. And then, so what are the NAR standards that creates this evidence base? Well, in the standards, each and every recovery residence has to have evidence that each resident develops and participates in an individualized recovery plan, and then evidence of an increase in recovery capital through things such as recovery support, community service, work, employment, training, etc. And so these are just part of the national standards adopted by SAMHSA. And then here we have SAMHSA's recovery housing practices and suggested guidelines, which are to promote and use evidence-based practices and then evaluate program effectiveness and resident successes. And as I go through this presentation, I'm going to show you a deep dive into the RECCAP platform that we utilize in the Virginia Certified Recovery Residences that really demonstrates that this is occurring. I think that we all on the call know that recovery is not a one-size-fits-all model, right? And so the ability to be able to identify an individual's specific individual's needs and then craft a recovery plan based upon their individual needs is really imperative to delivering directed, targeted recovery support services and assertive linkages to services that exist within a community. And so when we talk about the RECCAP platform, one of the things that we're doing is it's a strengths-based approach. And I've had the absolute pleasure of working with my mentor, Dr. David Best, for a few years now. And I always wondered what drew him to the RECCAP. And I'll give you a little bit of a backstory here just to kind of fill in. Dr. Best had been working in the UK in the prison system, and he kept seeing all these different reentry methodologies and different individuals trying to prepare an individual to reenter society. And the common theme was always these individuals kept telling the people who were getting ready to reenter society what was wrong with them. You don't have this. This is going to be a deficit. You're not prepared for this. You haven't done any work in this area. And Dr. Best kind of came up, his really aha moment was what if we start looking at what's right with an individual? What if we take more of a strengths-based approach and we look at, okay, within you as an individual right now, what assets do you already possess that we can continue to grow strength upon? And then rather than looking at deficits in a way, a negative, what if we just look at things as a barrier to recovery or an unmet service need? And really through the work of Dr. Best and John Kelly and others, the RECCAP, which is really the assessment of recovery capital, or the ARC, is where some of you may be familiar with the BARC-10 that Dr. Corey Vilsaint from the Recovery Research Institute developed. Well, the BARC-10 is just a shortened version of what we use in the RECCAP, which is the 75-question assessment of recovery capital. And so it's really all been evidenced through science over a plethora of years to really get to this point. And then what Dr. Best was able to do was, with the invention of the RECCAP, was able to take that science, take that recovery capital arc, and really plan it within a platform to really inform what an individual's strengths are in the domains of recovery capital, and then subsequently what are their unmet service needs and barriers, which would equate to negative capital. And then really what the platform does is it operationalizes the service delivery. And so our recovery residences really operate on the measure, plan, engage functions of the system. Just a really brief overview would be that an individual comes into a service setting, and that can be a recovery community organization. This platform is currently utilized in a jail recovery program called HARP in Chesterfield County. So the application of it transcends anywhere where recovery support services are being delivered. For these purposes, we use it in the recovery residence model. But essentially, when an individual comes into a recovery residence, they take the 75-question recovery capital evaluation. What that does is that's done with the individual and a peer navigator or some sort of a peer with them. They go through the process just like a regular recovery coaching session. And then what happens is the individual that's taking the RECCAP evaluation sits with the peer, and they go through and they look at the strengths and then the barriers and unmet service needs, and they develop a recovery plan together. And what the platform does is it operationalizes this into goals and tasks where local resources are in the system that other individuals have rated. And then the individual continues with recovery planning and check-ins on their recovery plan periodically as they accomplish their goals and tasks within the system. And then the client engages through a client interface. So the client always has access to view everything that's being done in the platform, which is a really important point, which equates to meetings and different things that are on their client schedule, things that they add with their recovery capital navigator or their peer. So it's really resident driven or individual driven. And then the RECCAP scales, this is actually in the system. Once a RECCAP evaluation has been completed, this is what it would look like. This is actually just in a sandbox that we have, but we're measuring quality of life and satisfaction, barriers to recovery, service involvement and needs, personal recovery readiness, social recovery capital, recovery group participation, other support, and then commitment to recovery. And this is really important because what we're essentially doing is we're essentially gathering this larger evidence base that is helping us to do more predictive analysis on retention, right? What are barriers to retention? What are common barriers through different socioeconomic deprived populations, different ethnic backgrounds of individuals that are in recovery housing or recovery support services? And then how can we better add the services needed where we can up our retention rates? And so this is what it would look like after the recovery capital evaluation is done. And then obviously the lowest score can be a -100, the highest score can be a +100. And then our typical average in Virginia upon baseline is about a 41.8. And so I'll show you what that looks like in real time as we continue to move forward. And then the next phase would be to really look at an individual that's had multiple evaluations within the RECCAP. This was a real client that was in the RECCAP for a period of time, as you can see, from 2/26/2020 to 2/19/2021. So, just under a year. And you can see, and then that was their date, but they continued in an alumni portal because that function obviously exists. And then you can see the longitudinal change in recovery capital. One of the most important things as we look into day 576 and on is that RCI index score never drops below 80, which is a pretty good predictor that after a year, this individual has got significantly higher chances than anybody who's less than 9 months to achieve 5-year sustainable recovery based upon the science. And so this is just a really good way to look at the meaningful impact, because oftentimes we see with recovery support services, peer services, that once somebody, has kind of reached a certain point in their journey, that they're okay, they don't need that ongoing support. But when we think about a medical model, even individuals with, let's just say, diabetes, even though they may be managing their diabetes properly through insulin and whatever the case may be, they still go to see their doctor for periodic checkups to see if the insulin is still effective, if there needs to be a change. Some people continue to need support in managing their diabetes. And so we want to think about recovery in the same way, and that just because an individual has done well for a period of time, that there shouldn't be a point in time where we don't want to continue to do routine check-ins and continue to provide support to an individual. And then so this is the recovery planning portion of it. This is what it looks like when the goals are set and an individual is engaging in their goals. And it's wonderful because when the individual through their client interface is checking off that they're engaging in something, I'll give you an example. If you go to a local AA meeting where there's a lot of recovery, or NA meeting, or some sort of mutual aid meeting where there's a lot of recovery residences around, about 5 minutes before the meeting starts, you'll see individuals take out a smartphone or their cell phone, and you'll see them all kind of doing something. It's a routine thing that happens in areas with high density of recovery housing in Virginia. And somebody unknowingly may wonder what the individuals are doing. What they're doing is they're checking in that they're at that meeting, that meeting was one that they selected to attend on their recovery plan, and the system's validating that they're there and they're engaging in that plan that, keep in mind, that's person driven, that they help design. And so when we think about the definition of recovery capital, the internal and external resources, this is just the kind of a snapshot of this. And this was a real client, by the way, that engaged in a variety of different services, both external, and then they continued to build up their internal resources throughout the different phases of their recovery journey while in the service setting of a recovery residence. And so this really gives everyone who's kind of viewing this the snapshot, not only of the evidence base, but more importantly, of the individualized recovery planning process. Again, recovery is not a one-size-fits-all model, and if we really want to support individuals to be the best version of themselves that they want to strive to be, then we have to address their individual needs on an individualized basis. And then this is what the client engagement portal would look like. Again, the client is able to view all of their recovery capital evaluations, all their recovery planning. They're able to look at their client calendar. They're able to check in on their goals and where they're at with the different resources that they're engaged in. And so it's just really a wonderful way for the individual to continue to have that ongoing snapshot. You know, I was in the Chesterfield County Heart Program with Dr. Best when he made a visit to Virginia from the UK. And the individuals in the Heart Program, a lot of them said that they oftentimes will print a snapshot of their recovery capital journey and send it in the mail to their loved ones on the outside to let them know the things that they are engaging in to try to further their recovery and better themselves prior to reentry into society. And so that's just a cool caveat of the individual being able to have the access to their own information. And some people may be wondering, the platform is HIPAA compliant. There certainly any data that's used in research purposes or utilized to be viewed publicly is certainly de-identified and is certainly compliant with all privacy policies. This is a provider dashboard. This is one from one of our VAR programs. Now, as VAR as a network, we have an overall dashboard. What's really important about this is recovery capital evaluations happen on intervals of a T1 evaluation is a baseline evaluation. That's when an individual first comes in for service. A T2 is 45 days, T3 is 90 days, and then T4 is 180 days. So it goes entry, 45, 90, and then every 90 days thereafter, as you saw in the previous longitudinal scale. One important thing to look at here is that upon baseline in this particular organization, the average recovery capital index score is a 29.34 now. That's a culmination of positive and negative capital that we covered earlier. Well, by the 45-day evaluation, that number is risen to 79.19. And I really want to make this important point. In a treatment model that where numbers for individuals are being tracked over, let's say, a 30 to 45 day time period, you would typically see exponential growth in the time they're in the treatment setting. And this isn't to knock treatment. I'm just, talking about recovery here. And so one of the interesting things about looking at this is you see that there's not this exponential growth. And then typically in the treatment models, we see a significant drop off upon exiting an acute care setting facility. One of the things we see here is we see a sustained growth. And that word sustained is so important because the goal is for individuals to achieve sustainable recovery. So in this particular organization, by the T6 evaluation, which would be done within the first year, you see that there's been a steady trajectory of growth in recovery capital, that we haven't seen that typical dip that we would see in other more acute care models. And then this is just another version of the dashboards. And the dashboards, I mean, I could do a whole presentation on everything that an organization can see in their overall data for their dashboards, from longitudinal RCI scores and how that correlates with the domains. You can really just take a deep dive into every aspect of the RECCAP and look at areas where an organization may be performing strongly and in areas where an organization may have a need for improvement. But, this is just a good little bar chart to show that growth in recovery capital, and subsequently we see the negative capital, how it shrinks over this time period. And then as Adam had kind of said when he was delivering my bio to you all earlier today, we did just recently in 2023 publish an evidence-based research study in the I believe it was in the Alcoholism Treatment Quarterly Journal, and it's using recovery capital to predict retention and change in recovery residences. So one of the things that we want to do with data is not just show the effectiveness of this evidence-based practice that we have implemented, not just show how effective recovery housing is, but we always want to look at it for where are we losing people? right? Where can we up our retention rates? Recovery residences in Virginia served well over 6,000 individuals last year, coupled with recovery community organizations. And so we want to continue to further our evidence base. We do have 3 other papers that have been submitted for publication that are under peer review. One of them takes a deep dive into intensive support programs, which some recovery residences offer. And then the other one is on criminal justice and non-criminal justice involved populations and what their outcomes look like when they engage in recovery residences. And this is just kind of a snapshot of some of the things I was just talking about for our ongoing and future research purposes. You know, and then we also are looking at doing a large cost analysis scale on basically what we want to answer is what is the public health savings to the state of Virginia for each person that's in a recovery residence as opposed to being in an acute state out on the streets. So we think about the cost savings from uninsured and emergency room visits to any aspect of the public healthcare system. And so we have submitted a funding proposal to get that funded so we can provide that cost saving analysis to the Commonwealth. And then as we were talking about, we really want to take a look at what are some decisions that have been made based upon having this in-depth data platform that provides a recovery support service tool for individuals, but also provides us with a snapshot and how we can improve. And here you'll see a couple of projects that have been funded using funding for addiction services that flows from SAMHSA to the Department of Behavioral Health and Developmental Services. And you'll see a real life reentry recovery residence. Why that's in there is when we first got our dashboard up, we saw that African-American women ages 19 to 26 had almost double the barriers to recovery as the rest of the population. And then that 26 to 40 range had significantly higher barriers than the average population for African-American females. And so one of the things that the state did was they agreed to fund some reentry specific recovery residences for this population so we could try to mitigate that barrier in the population we were seeing being served in recovery housing. And subsequently, we also noticed that there was a gap in LGBTQIA+ recovery residence beds or transgender supportive beds as well, not basically a non-binary recovery residence organization. And the state also funded for the first LGBTQIA+ recovery residence organization to be funded and established, and they currently operate 11 beds in the state of Virginia, which has been a tremendous, wonderful resource to make sure that people are able to get there, to have access to recovery residence beds. And one of the things that Adam was talking about with the bio, one of the things that we certainly were able to do was we were certainly able to break down some barriers and go out and advocate for funding. The advocacy work around this funding was really centered on, again, utilizing the data platform to identify why we weren't serving individuals that were non-Caucasian. You know, we know that the state census population for non-Caucasian individuals in Virginia is certainly higher than 20%. And we certainly know that individuals could have had some sort of a barrier to accessing these recovery residence beds. And I want to preface this by saying that recovery residence beds are not Medicaid funded. Recovery residences do not accept insurance. They are not a licensed facility that bills Medicaid. A typical recovery residence model is an individual may need some help, whether they're from reentry or from inpatient treatment or just coming off of the street to get into the recovery residence. And then after a short period of time, whether that be 25 to 45 days, the individual gets a job and begins contributing and paying their own weekly fees to live in that recovery residence, which in a recovery residence is generally going to be a nice single family home. And so what this funding did was it allowed us to really have an impact on changing the faces of the individuals that previously didn't have access, but now do have access into recovery housing. One of the things that we really noticed in our most recent data set, which is within the last 6 months, now that we've seen this increase in non-Caucasian populations entering recovery residences because we've been able to mitigate the financial barrier, we're also beginning to see retention go up for this population. There'll be a future research paper on that. But what that lets us know is that based upon what we're able to see and quantify through the data that we're able to look at resources that need to be added to up our retention rates and keep people engaged in recovery residence and peer support services. This is just an overview of what the funding provided. That large ARPA funding allocation that we utilized provided ARPA year 1 and year 2 have provided over 83,000 indigent bed nights. And I also want to make this point is that recovery residence beds also help curb a homeless population. A lot of individuals who are considered homeless, really a large percentage of them, I believe the national average was 73%, but don't quote me on that, but they have a substance use disorder. And so when we talk about creating accessibility into recovery residence beds, we're also having a significant impact on the homeless population as well. And then we've been able to offer over 270 30-day program service scholarship funds to organizations that operate that intensive support program. And what that basically is some recovery residence organizations have a recovery center and transportation, and it's really for the first 30 days a really intense wraparound service with an assertive linkage into clinical or mental health services as well. Typically, those programs are used on individuals that have 20 points lower recovery capital score on intake. And what the research paper is going to show you is that by the time that 45-day evaluation occurs, that those individuals that started with a significantly higher deficit upon intake have closed the gap with the regular population, which just certainly shows the effectiveness of the assertive linkage programs through intensive supports. Part of the funding was also used for a minority ownership and mentorship program in the recovery residence space. So a portion of our funding has went to establish a minority ownership in the recovery residence space. I think over the last 2 years, we funded 7 minority-owned organizations that currently operate recovery residence beds throughout Virginia. And then rural areas have been a major, or underserved communities have been a major focus for us as well. And that's one of the unique areas that VAR has significantly been able to have an impact. We went out and we advocated for this funding, and we've utilized it to start some rural area projects. And here's one of them from Russell County, Virginia, which is a rural area up near Lebanon. And what we did was we essentially went out and we got this funding, and then we were able to provide the technical support with our funding in partnership with Russell County, their drug court judge, their county administrators, and we provided technical assistance in identifying a stakeholder group, kind of building a model with them for them to support their own community. And that organization, their board and all their staff are from their local area. So it's not as if VAR finds people to outsource to them. We just provide all of the resources needed to be able to go out and identify who can own and operate this. I'm really happy to report that since this program got started, they have a wait list. What the funding did was it provided 20 men's beds and 8 women's beds on a campus across the street. And it also provided an open to the public recovery center with peer staffed in there. And so it's been super impactful because that's a county of only about 8,000 individuals. And this is some of the change, as you can see, in those Caucasian versus non-Caucasian numbers that really bode to the funding creates an accessibility, eliminates a funding barrier, which equates to an accessibility problem for individuals. And we noticed that significantly impact non-Caucasian individuals the most in our state. And so we've been able to garner the funding to be able to mitigate those barriers and significantly increase the non-Caucasian individuals gaining access into recovery housing. And this is just another bar graph, which really just has a bit of a different impact when you look at what the funding has really been able to do. It's one of the things that we're really proud of, really just being able to make recovery residences available to all individuals, regardless of background, criminal justice involved or not, socioeconomic deprived or not, different cultural backgrounds. We just want the accessibility to be there for people to access recovery housing. And on that point too, just as a little FYI, a lot of people wonder, where is the largest number of individuals that are achieving sustainable recovery that are in early recovery? It was a question asked about 18 months ago And after the researchers began to look into it, what they determined was they live in recovery housing. In our country, in the United States, the largest number of people that are achieving sustainable recovery who are in what's considered early recovery, they live in recovery housing. And so, again, it just makes the case for the importance of these community-based resources that oftentimes partner with different criminal justice outfits. A lot of drug courts in our state utilize recovery residences for the people who are in drug court. And certainly all of the caseworkers and reentry individuals through CSBs or various treatment centers utilize recovery residences as a next stop for individuals who they may be serving and referring to as well. And that kind of concludes the slides, which I know will be made available to you. And from there, I will stop sharing my screen. I don't know if there are any questions in the chat box, but certainly happy to answer any questions I may be able to for you all.
That's great. Thank you, Anthony, for sharing the power of recovery residences and how data can make choices and inspire people to share with their families. That point was really powerful for me. It helps bring the families in to support them as well. Thank you for sharing that. As Anthony said, I will be sending an email out to everyone. The follow-up email will include the video link to this session, as well as any resources that Anthony would like to share with you. So if you have any questions that we haven't yet answered, please include them in the chat, and we can do that for you now. Here's one. Do you believe that if recovery houses could be paid for by insurance, this would decrease the motivation for an individual to look for work or decrease the effectiveness?
Yeah, so that's kind of that's a very loaded question. I know that NAR, the National Alliance for Recovery Residences, has been working with ASAM on where we certify based on 4 support levels. A level 1 is basically a democratically ran model. We don't have a lot of those. The closest to that would be a separate entity called Oxford House or Oxford Charter Houses. And then our most prevalent models are level 2s and level 3s, which have a very pointed infrastructure with residents, some sort of live-in peer leader with experience in recovery, and then staff above them with really well-defined policies and procedures to include reoccurrence of use policies, grievance policies. Part of our standards is naloxone has to be available in all recovery residences. Again, recovery residences are abstinence-based, but again, that's a really topic that a lot of people misconstrue, because all of our recovery residences in Virginia allow medications for opioid use disorder. We're one of the few states that has that really large buy-in on being MOUD capable. And so the question is really the insurance piece. So when you think about recovery residences, think about community-based organizations that aren't in behavioral health services. And so what does that look like for them? Do they have to hire clinicians? Do they have to have a billing staff? How are they going to get paid by insurance? That's a huge fear of recovery residence operators, because they're not in that side of the industry. Secondly, what we've seen that goes along with the question, does the funding accessibility or the ability for insurance to pay deter the individual from going out and getting a job possibly, right? We found that to be the opposite. Now, I will tell you, since COVID, Dr. David Best reviewed our data back in 2021 into now, and we've seen that 80% of the individuals in recovery residences have a co-occurring use disorder. Which means that they have additional disorders other than just a substance use disorder. And so I just say all that to say that the criminal justice system is a large referral sources, as well as other treatment centers. And so typically an individual is going to need 30 to 45 days to get all their documents together, to kind of maybe find local providers if they're transitioning from outside the area, as well as just really engage in some recovery support services within the recovery organization, whether it be resume writing. Our providers generally a lot of them offer a lot of different skill set classes to help an individual become employment ready. So we just haven't seen the funding deter people from taking some responsibility for themselves. And what we typically find is that most people who are even on some sort of an indigent bed scholarship for a period of time are really eager once they kind of get their feet underneath them and begin building that foundation of recovery, they're really eager to get back in the workforce. We have to remember that for people in recovery, whether it be mental health or substance use, there's a lot of self-esteem that comes from getting out in society and being a part of the workforce and earning their own living wages and things of that nature. And so we just haven't really seen that be a big deterrent.
At this time, we don't have any more questions, but I would like to take a moment to once again thank everyone for joining us today and remind you that the Abatement Academy series continues every second and fourth Thursday through 2023. You can register up until the morning of. We'd love to have you. Here's a question for you, Anthony. Do you have any thoughts on prevention based on all of the cases that you've seen? Root solutions, as I can assume, you've seen enough cases to have this sort of insight.
Well, prevention is really a wide sweeping term that we use. Can you be a little bit more specific, if you don't mind, whoever asked the question? That way I can really direct my answer appropriately.
Mary, would you like to unmute and ask your question a little more pointedly?
Yes. Hi, can you hear me?
Yes.
Thank you. I'm just thinking about how you probably have a unique insight meeting so many of these people firsthand. Is there some sort of trend that you're seeing that maybe most people just aren't aware of, something that, for example, could be such an easy policy change or anything in our society that could be different, that could prevent so many of these people needing this type of recovery?
Yeah, I love the question, Mary, and I love where you're going with this. So let's think back 10 years ago, which really isn't that long, but what we've seen is 10 years ago, there were no recovery high schools in our country. Today, we have over 180 recovery high schools. Now, we're talking about specific high schools for people who are in recovery from mental health or substance use disorder, which is a significant change. What does that tell us? That tells us that our young people today are being introduced to much harder drugs much earlier on in their lifetime, right? That our youth are being exposed to things that 10, 20 years ago they weren't exposed to. And so when I hear the word prevention, we know that the DARE campaigns and the Just Say No's, they were ineffective. Okay, let's just be honest. They were ineffective. They actually had the opposite effect, because I'm a person in recovery, and I'm gonna tell you like this, okay? I can be on a Sunday wanting to come home after I've gone out and ran a few errands, and I can come home and want to cut my grass, right? Now, if I walk in my door and I sit down for a minute as I'm getting ready to go out and cut my grass, and my wife tells me, "Are you going to get out there and cut that grass?" My brain automatically tells me, you know what, I don't even want to cut that grass anymore because you just told me I had to, right? And so that's just the thought pattern that I have with some years and years in recovery. And so I say that to say that, prevention is so different now, the way I believe, and this is my belief. I think that telling people to never try certain things, or, I really, and I have a child who's in VCU currently, and her mother and myself, our message to her has always been, don't try alcohol, don't try these different more recreational substances that young people may experiment with in high school or college. Our message has always been like, hey, if you get out and you try different things and you find it's a problem, from our past experiences that it's okay to say, hey, look, I've been doing this and I'm having a bit of an issue. What resources do I need? Can I get a little help? Whatever the case may be. I really believe that our prevention efforts should be centered around wherever young people are congregating, whether it's boys and girls clubs, high schools, whatever the case may be. I think we need people with lived experience going in there and talking to them about their stories, not from a perspective of just say no, but from a perspective of, hey, I went through this and I was able to turn my life around, and I was able to recognize that this was having a negative effect on my overall well-being.
Anthony, I want to thank you again for to us. This has been wonderful. Adam, can you speak to anything that you want to share with everyone about the Opioid Abatement Authority?
No, just that we've got a lot more coming up, right? And I know, I think Vig is sharing that information, right? And I think that may go out at scheduled times, but you can certainly see the entire agenda or itinerary that goes through December of this year on the OAA's website. So please join us again. There's a lot of good material there that covers the five different like program areas, right? So this is using funds towards evidence-based type uses for opioid abatement. So yeah, just want to thank you, Jennifer, and the Virginia Institute of Government, and Anthony for sharing all of those experiences with us today. So thank you.
All right, everyone. Thank you again.